and the organizing committee to invited me in so prestigious meeting, and I'm sorry really to not be in the presence, but circumstances, regulation oblige me to stay home. And so the lecture is on Mako, robotic assisted surgery. I need to disclose my Stryker relationship because I'm receiving consultant fees and royalties. The most important feature for the Mako CT-based robotic system is the haptic control in bone preparation. The surgeon removes only the planned volume bone within predefined boundaries and with visual, tactile, and audio feedbacks. There is no need of retractors or cumbersome cutting jigs, and the accuracy of the cuts can be checked intraoperatively. The first application in my department of robotics has been partial knee arthroplasty. I started using Mako in 2014 in medial, lateral, patellofemoral, unicompartmental arthroplasty, applying correct indication. Robotics is a useful tool also in bicompartmental and biunicompartmental knee arthroplasty. Robotics in unis has demonstrated excellent early functional outcome at 2 years, high patient satisfaction, and less revision rates compared to conventional unicompartmental arthroplasty at short-term clinical outcomes, and you can see literature outcomes. Only few studies have reported on robotics, unicompartmental arthroplasty, survivorship, and clinical outcomes at midterm 5 years. Our groups and groups of Pearl have recently described a survivorship of 97% at 5 years, with excellent clinical results in terms of forgotten joint score, functional outcome, KOOS scores, and patient satisfaction. These are causes of unicompartmental arthroplasty revisions reported by our group in a recent publication on KSSTA. We have a cumulative survivorship of almost 98% after 6 years of follow-up, with unexplained pain being the most common reason for unicompartmental revisions. We demonstrated less revisions both in terms of component aseptic loosening and osteoarthritic progression compared to conventional mobile and fixed bearing uni, as reported in the literature. In particular, in contrast with the data reported by Berger on BJJ, we reported no cases of uni revision due to OA progression. The success of robotics is determined by the possibility of modifying implant positioning based on the intraoperatively soft tissue balancing throughout the knee range of motion. Soft tissue tensioning is the expression of femoral tibial components' geometry gap at different degrees of knee flexion. By reducing the number of outliers, robotics can also help to investigate the role of OA grade on clinical outcomes. We recently presented the preliminary results of this study of the 2020 American Knee Society and found a confirmation that patients with preoperative ALBAC, more than one, had a higher probability of forgetting their knee compared to patients with less OA. The second application of robotics in knee surgery is total knee arthroplasty. We started using Mako for total knees in 2017, and we had the opportunity to use it for cemented or uncemented total knee arthroplasty, both in the PS and CR design. Actually, I'm using mostly CR uncemented implants. Preoperatively, the surgeon can decide his favorite alignment target, either mechanical, kinematical, or functional. Intraoperatively, after gaps measurement, he will either go for soft tissue releases or component fine-tuning adjustments. The latter is what we have been using 98% of the time. Femoral tibial component can be aligned mechanically in the coronal plane, checking for bone cut thickness, or kinematically by aligning the cut to the femoral and tibial resection landmarks. And you can use both X-rays or CT, as you can see in the slides, on the right. In both cases, it is important to assess bone erosion when the preoperative planning is performed and also check intraoperatively if the bone loss is present. What we do following the functional alignment principles. Femoral and tibial components are anatomically aligned in the preoperative planning. Intraoperatively, I check for deformity correctability after osteophytes removal and ACL removal if I do a PCL implant, and then check for flexion extension gap after ligament tensioning with spoons. Femoral and tibial components are then fine-tuned based upon the flexion extension gaps. Fine-tuning is meaning that we can modify implant positioning in the 3D planes in order to obtain the desired medial and lateral gaps in flexion and extension, meaning between 18, 19 in the medial side, 19, 20, 21 in the lateral side in both extension and flexion. It's possible to check for bone cut thickness and orientation and assess limb alignment in the coronal and sagittal planes. After implant fine-tuning with balanced knee, we can end up with a varus tibial cut, like in these patients, and a varus femoral cut, and slight femoral external rotation relative to the transepicondyle axis, probably trying to mimicking the constitutional alignment of the patient. Recent publications have demonstrated that robotics represent an outstanding tool for reducing soft tissue damaging during cutting procedure. And this meaning also less pain after surgery, because pain is related to soft tissue damage. The group of that had described a new classification system for soft tissue injury and reported less soft tissue damage in robotic surgery, in particular to the posterior joint capsule and medially, in a prospective comparison of 30 conventional and 30 robotic total knee arthroplasties. According a study by the group of Mont described less damage to the PCL, because with the haptic control we can really tune the bone cuts in front of the PCL, and so avoiding the PCL damage. And so the island that we maintain in the surgery is absolutely perfect. Robotics in total knee arthroplasty has demonstrated improved accuracy over conventional total knee arthroplasty in terms of component and limb alignment with no learning curve effect. And so this is great because you can have very accurate surgery in the first cases. Although the short follow-up to 1 year robotic-assisted total knee arthroplasty with Mako has shown promising early clinical results. What is more relevant, however, are the decreased pain, decreased reduction of post-operative hemoglobin levels, and reduced analgesia required. These factors determine enhanced early function and reduced time to hospital discharge compared to conventional total knees. In conclusion, robotic nowadays is an important technology, both for uni and total knee arthroplasty. Robotic uni has demonstrated improved early functional in patient satisfaction compared to conventional surgery, with the house survivorship results at minimum 5 years of follow-up. Relative to total knees, the follow-up is short, but the clinical and functional results are promising, with a high accuracy in bone cuts and less alignment outliers compared to conventional total knee arthroplasties. Thank you very much.